The eighth cranial nerve is the vestibulocochlear nerve, and as the nerve implies, there is a vestibular component and a cochlear component. The cochlear component is involved in hearing. This is a sensory nerve and innervates the cochlear. A gross assessment of hearing would be just to rub the fingers outside the external acoustic meatus to see whether or not the patient can hear gross sounds. In more detail, you should distinguish whether the patient has any signs of conductive or sensorineural hearing loss. Conductive hearing loss occurs when sound is unable to effectively transfer at any point from the outer ear through into the inner ear. That includes the external auditory canal, the tympanic membrane, the middle ear, the ossicles. Conductive hearing loss can occur due to excessive earwax, otitis externa, otitis media, a perforated tympanic membrane, or otosclerosis or presbyacusis. Sensorineural hearing loss occurs due to dysfunction of the cochlea and/or the vestibulocochlear nerve. Causes of sensorineural hearing loss would include age, excessive noise exposure, genetic mutations, and viral infections such as cytomegalovirus, as well as ototoxic agents, including antibiotics such as gentamicin. The Rinne's and Weber's tests are used to help determine whether the patient has sensorineuronal or conductive hearing loss. For the Rinne's test, place a vibrating tuning fork of a 512 Hz firmly over the mastoid process, applying pressure over the opposite side to make sure contact is firm. When the patient can no longer hear the sound, place the same tuning fork over the external auditory meatus, and the patient should report that air conduction is better than bone conduction, i.e. the sound is transmitted better when the tuning fork is vibrating over the external auditory meatus rather than over the mastoid process. The Weber's test is where the 512 tuning fork is placed in the midline of the forehead, and a patient is asked to localize whether the sound is traveling equally to both ears or whether it's heard better on one side or the other. In terms of interpreting this test, in a normal patient, air conduction would be better than bone conduction in the Rinne's test, and in the Weber's test, the sound should localize to the midline equally in both ears. In sensorineural hearing loss, air conduction would be better than bone conduction in the Rinne's test, but the Weber's test would cause sound to localize to the normal ear. In conductive deafness, bone conduction would be better than air conduction in the Rinne's test, and in terms of the Weber's test, the sound will localize towards the affected ear. Now the vestibular component. The vestibular component is involved in maintaining position. There are two key tests. There is the Unterberger or turning test, where a patient is asked to march on the spot with their arms outstretched and their eyes closed. A normal result to the Unterberger test is the patient remains marching facing the same position. In a vestibular lesion, as the patient marches, they will turn towards the affected side. Another important test is to examine for the vestibular-ocular-reflex. Ensure the patient does not have any neck pain or neck movement disorders. Sit the patient facing directly opposite to you and ask them to fix their vision on your nose, hold their head, or ask them to rotate their head from side to side, all the way to the left, all the way to the right, and a normal response is they're able to maintain ocular fixation on your nose. In a patient with a loss of vestibular function on one side, the eyes will first move in the direction that the head is rotating to, that's known as loss of fixation, before a corrective saccade then occurs to try and correct and exercise the vestibular-ocular reflex. So in summary, to examine the vestibulocochlear nerve, perform gross hearing test, perform the Rinne's and Weber's test, and then perform vestibular testing with the turn test, and then examine the vestibular-ocular reflex. Thank you for attending this medicine masterclass.